Now I'd like to introduce Dr. Blaise Aguirre. Blaise is an assistant professor of psychiatry at Harvard, and he is also the medical director of the adolescent program at 3 East McLean Hospital in Belmont, Massachusetts. And he's going to be speaking to us today about stigma in terms of patients who have BPD, which I think we can all relate to, both for the families, for the patients themselves, and even as professionals treating these patients, I think we often feel the effect of stigma. So we welcome you, Blaise. He's also the spearhead of this conference, so we thank him for that.
Okay. Hello? Okay. So, hello? This is on and off. On and off, on and off, on and off.
As the other one comes out.
Oh, the other one comes out. Okay. What's this? I can go back.
Check.
And, no, it's, okay, I'll just use this. Okay. I'll just use this one. Thanks very much. So where's Alec Miller? Alec Miller said that tweeting is a 21st century attachment. And by that token, Efren, who I had only heard of, but just met today, I'm very attached to him because I've tweeted him multiple times during the course of his speech, and I just hope it was contingent tweeting. One of my patients who follows me on Twitter says, "Dude, you're emotionally dysregulated. We've got, my cell phone keeps going off with your tweets, enough already." So, can I just get a sense also, therapists in the audience? And okay, family members? Okay, and people who self-identify as BPD? All right, thank you so much for coming. Just a couple of thank yous. Obviously, UCLA and Robin, who's gone to great lengths to put this together. Perry Hoffman and the nea.bpd. It's a fabulous organization, and just great to join. Also want to recognize some friends of mine, the Menukuris, who are here with us, who tragically lost a daughter to BPD, and they have been very strong advocates for dissemination of information and knowledge about this condition. And they're here with us today. So 3E, so our unit is a predominantly DBT unit. It's 95%, although we do use mentalizing as well. And so residential unit that we started about 6 years ago. And I had been fighting with the hospital for a dedicated treatment for borderline personality disorder for adolescents. And they gave me 2 beds eventually 6 years ago. And they said, you know, I mean, it was a joke, what happens when you put 2 borderlines on a unit, which is not that much of a joke, because in reality, we know statistically that 40% of people on inpatient units have borderline personality disorder, but nevertheless, there you have it. And today we have 29 beds across our continuum, and we have a partial program that has 12 patients. So, and the reason we did this residential, though residential was never part of DBT, has to do with, there are times when just the parents are burnt out, times when the kids just don't feel that they can do it anymore, or that there are no services in their home communities, and people have come from all over the world to be on our unit. But the majority of people who receive treatment, if they receive treatment, do so on an outpatient basis. So certainly our model is not the standard of care, and most people ought to be receiving treatment on an outpatient basis. The other thing is this. This year has been a year of travel. I've been in the Middle East, Europe, all over the United States lecturing on BPD. And the attitudes that people bring to BPD are so varied depending on where you are. And this might be a very BPD-friendly audience, but I was in the Midwest a couple of weekends ago, and a therapist stood up and said, look, I just refuse to treat these people, because I have a perfect record, and I don't want to be blamed for treatment failure. Now, I had the urge of using the microphone as a blunt weapon, to be honest with you. But you get it too. But part of that is that lots of people just don't know about this condition, and so for me, fighting the stigma has become like the thing. And so here I am. And so these are just, this is just true of lots of aspects of mental illness, but it's also definitely true for borderline personality disorder, that these negative attitudes lead to all of these sorts of things. Certainly isolation, not feeling understood leads to more not feeling understood. You don't want to seek mental health help. It's interesting that for a condition that affects 6% of our population, the amount of funding a couple of years ago was about $6 million, which is it's remarkable. 40% on inpatient units have borderline personality disorder, 20% in outpatient units have borderline personality disorder. It wreaks havoc on families and on individuals, and we have $6 million in funding. It's awful. Shame, insurance reimbursement. The number of times you speak with an insurance company and say, I've got a patient with borderline personality disorder, and either click or, well, we don't cover that, or things like that. So then what happens is that the clinician is then forced to say, add the comorbidity, the thing that is maybe not getting the patient into so much trouble, and borderline, and bipolar, and depression, and ADHD, well, that we'll pay for. So it's a huge issue. Now, we the clinicians are the ones to blame for this, if there is blame. Now, in DBT we don't like to look for blame, but I'm totally with Alec on this, and that is, because we didn't understand and know how to treat people with BPD, we started to describe their behaviors in ways that made them very unappealing for other clinicians to treat. So it's all of us, and because we as a community of therapists so stigmatized people with BPD, it is really up to us to start undoing some of the damage that we've done. All right. So why does this stigma develop? Let me just see here. Okay, so let's just get to what the stigma is. I'll get back to this slide. And certainly if people have a very specific example, I know we're going to have a longer time to discuss it, but if someone's compelled to give an example, please do so. Manipulative. So here I am a clinician that is seeing somebody like this in my practice, and I'm going to refer this person to somebody else. I'm not going to see too many people lining up to take this person. Manipulative. If we can remove it from our lexicon in terms of borderline personality disorder, that would be great. But let me say a word about that, because not to say manipulation does not exist. We have every Tuesday at McLean borderline rounds, and we have people from all aspects of treatment: cognitive behavioral therapy, dialectical behavioral therapy, psychodynamic, psychotherapy, mentalizing. And it's quite interesting how people use words. So aggression in psychodynamic psychotherapy can be acts that are interpreted by the psychoanalyst as unconscious defense mechanisms, whereas in DBT and behaviorism, and Michael Hollander, who works with me as a DBT trainer and enjoys boxing, for him, aggression is, someone puts on a glove and slugs someone, or maybe doesn't put on the glove and slugs someone. Now that's aggression. Now if I'm thinking aggression behaviorally in that way, and a psychodynamic psychotherapist is thinking about an unconscious defense and using the word aggression, it's going to trigger different thoughts about specific behaviors in each of these people. So often the word manipulative is used to describe borderline behaviors, but I think it is absolutely critical, and this is borrowing from mentalizing, to take an extremely curious stance, because the intention to manipulate may not lead to the effect. The effect of feeling manipulated may never have been the intention in the first place. The intention to manipulate may lead to feeling manipulated, and they may not feel that they're going to manipulate, and you might not feel manipulated in any case. So there's a difference between intention and effect, which I think we have to pay a lot of attention to. But we talk about it as if it's manipulative, this sort of knowing what is going to get you to do something. But by that token, we're all manipulative every time we buy someone a bunch of flowers or a box of chocolates or something like that, that we're maybe changing behaviors. But it's just this unwanted effect, the feeling that we are duped. But very often, it's just been behavior that, as Alec points out, has been reinforced time and time and time again. Not to say that manipulation does not exist, because it does, but all unwanted behavior is not manipulative. Splitting. So the idea of splitting, which often people talk about, is a psychodynamic term, and the way it worked was this, is that internal to people with BPD, there's these extremes of feeling of being good and being bad, more often than not being bad, and those internal feelings are then put on staff people, and then staff people start fighting with each other about what's going on, and then that's called splitting. So that's something that the patient is doing to us. But if we disagree in every other context, we don't call that splitting. So the thing is that it's true that people are going to have different points of view on a situation. And the reality is that often happens because we have different information. So by the time Alec gets down to the calm kid who's taken her PRN, your out of control patient is now no longer out of control. And so we're bringing some informational set to a situation and making a decision based on that. If we imagine the best of each other, why would we want to make our life on inpatient units or clinics or anything more difficult for ourselves and for our colleagues? Often we don't, but we're bringing different information sets. So this idea of splitting, blaming behaviors, promiscuous. When do we use the word promiscuous? The problem with promiscuous is it implies sluttiness, a judgment, but it doesn't get to the function of what the behavior is. Why is a person having multiple sex partners? What is the function of that behavior? So rather than simply using the word self-defeating. Why somebody would want to do that again? I don't know. Attention seeking. And even if you look at statistics on self-injury, only about 5% of self-injury is so-called attention seeking. But the number of times that emergency room doctors and other people talk about this behavior as attention-seeking behavior, when in fact, they say, well, really, well, this is pretty interesting. How long has the person been doing it? Well, about 2 years. When did you find out about it? 3 weeks ago. Boy, that's very poor attention-seeking behavior. Took them 2 years to find out. Unmotivated. You're going to be unmotivated when you're doing something that doesn't make sense to you, that doesn't work for you. Many kids say they love their therapist, but they sit there and they talk about their day. Now, for some people, talking about their day may be exactly what they need, a supportive psychotherapy. But for many of our kids, simply talking about your day gets you nowhere. Ultimately, DBT is a cognitive behavioral therapy. There has to be change, because staying the same means that you're stuck in your life. So there has to be some change. So how are you able to affect that change, and what's the model for doing it, whether you're using mentalizing or DBT or CBT or whatever. Bad parenting, very common. Dangerous, weak, crazy, dangerous patients. So, given that, you can see how those BPD symptoms can be frightening and frustrating for clinicians. And, you know, certainly growing up as a psychiatrist, the word was used as an insult, as a pejorative, so many times. I mean, I'm sure that I did it too. Oh, that's so borderline. Never say anything else about any other condition. That is so diabetic. That is so asthmatic. You know, we would use this word, this diagnosis, as a way of insulting people. And then it was worse, because now we have the nurse who's not doing what you want that nurse to do. She's being so borderline. So we took this word that had strong clinical implications and used it as a way of describing bad behavior. The other thing is that, you know, again, I mean, what other thing? Schizophrenia has suicide, bipolar has suicide, major depression has suicide, certainly anorexia has suicide, lots of mental health conditions, but we don't use those terms as a way of insulting others. So then, there's this idea that we make this diagnosis, but then it's a hopeless case. And once you get that, and then the misinformation starts to spread, then it just perpetuates this story. Fear that if it's a borderline diagnosis, well, that's all about the environment, as opposed to the genetics and the biology. And as the two previous speakers said, there's increasing evidence that there's a very strong biological component. And some would argue it's, of all the mental illnesses, maybe the strongest biological component. Again, this fear that I will be blamed. I am that important that I am going to be blamed for your failure, and I don't want that. I only want patients who are going to think I'm fantastic and who are going to have great outcomes. You know, so you better not blame me. Now, so this is just a slide about reducing stigma. So it's interesting that if we say it's biological, then it's, oh, that's okay, then it's much more accepted, there's much less stigma than if we say that something's environmental. And yet, what is absolutely critically true is that the environment and biology interact with each other to produce illness. So if you are asthmatic, for instance, and you work in a coal mine, it's going to be much more triggered in that environment than if you don't. And these things are playing off of each other all of the time. So there's a tendency by some of us to say, well, this is purely biological. Now, it is purely biological because the brain's a biological entity. But what I'm saying is that the way that the environment changes how the brain functions is not well understood. So you might be able to see wonderful scans, which we do, about the brains of people with BPD, and that research needs to continue. But you have to start, once you start drilling down, like what happens to attachment? What happens when you start attaching? What does attachment look like in the brain? It's a very, very complicated thing. It's got stuff going on all over the place. And that these are transactions, and the transactions are represented in this biological organ, which is the brain. So it's a distinction that ought not to be as important, and yet, you know, it's biological, well, that's okay then. So, what are the myths? And this I borrowed from my, I want to be a really excellent clinician, so from Efren, I'm just stealing as much as I can. So this was from my colleague John Gunderson up at McLean. So that BPD patients resist treatment. Big myth. They don't. But what happens is that what they do resist is treatment that doesn't work. Well, that's true of anything. You go to your dermatologist because you've got a bit of a rash, start prescribing you cardiac medication. Eventually you're not going to go because your heart's actually doing fine. But they say, well, they're resisting our treatment. Well, you're going to resist treatments that don't work. Certainly treatments where you don't feel that people understand this. The borderline patients angrily attack their treaters. Now, we are a residential unit, and we've had maybe 600 of the most suicidal, self-destructive, angry patients with borderline personality disorder, and I have not been attacked. And I'm just saying that often, what happens transactionally between people is that when you don't feel understood, your voice gets higher and their voice gets higher, and you start yelling at each other, and then you feel, well, I feel attacked, and well, I feel attacked too. So you go back and forth, and then you start feeling attacked. It's just one of those things going to happen. But it's just it's not. Yes, of course, there's always going to be a situation where somebody does attack their treater, but it's just not a common practice. Borderline patients rarely get better. Once you, no, don't make the diagnosis, because then they're not going to get better, as if, that's what's going to change it. But it actually flies in the face of research that in 2 years without extended or stable treatment, 50% of people will get better, will be in remission. That you have to be an expert to treat this. And I think that people like Gunderson and others are saying that some of the treatments that we use, like mentalizing and DBT, are somewhat complicated to learn and to apply, and that there's some general principles of treatment that can really help, and people are trying to develop, just a simpler way of implementing these treatments. And it's true. I mean, one of the things that we have to be very careful about, and we've noticed is that, okay, so here's this kid who's had 10 hospitalizations, been in 15 individual therapies, and they come to our unit, and it's, feel understood. And how good is that? Not only do the clinicians understand me, but the people around me understand me, and I ain't leaving, So we have to be careful that we as clinicians then don't reinforce their staying so much that it then becomes, well, they're going to be their life for the rest of their life, these excellent patients. This idea that we're going to get sued, honestly, if you were to say as a clinician that the threat of a patient and their family suing you for treating their kid, you have to, that means that lots of people would not treat patients who are potentially ever going to be suicidal, and that these patients would continue to suffer in these ways. And you have to continue to fight and deliver compassionate care. And I have not met litigious families who say, well, that's something that happened, and therefore we're going to sue you for that, or sue you for that. It's just not the case. Certainly, if you're going to be negligent, and certainly if you're not going to pay attention to obvious situations and threats, well, obviously you're opening up yourself. But that's true of any treatment of any condition. So one of the things that I had done, and I was hoping she was going to be here, but she couldn't, is I'd shared these slides with a mom who's really struggled with a borderline diagnosis in her kid, even though she's part of the nea.bpd and joint and wants to do the training and does a ton of DBT. And she just said, you've got to speak more to this thing about adolescence, which I've spoken to for a long period of time. The idea that it cannot be diagnosed in adolescents and young people, that they're viewed as more difficult than others, that some say that they're less mentally ill, because for many people with BPD, there is great periods of normal functioning, typical functioning, healthy, effective functioning, and it seems that it's only in the context of very intense relationships that things seem to break down. See, you see, she was crazy. well, no, she's acting normal now, but she was crazy just 10 minutes ago. You know, it's this reactivity of BPD. And then the parents think, you know, I know you think I'm crazy, but I'm telling you, she's out of control. And so that there's great periods of stability, and both are true, that there's great periods of stability and great periods of instability. The other thing is that I've had a heck of a time recruiting psychiatrists for many reasons, but because medications, at this point in time, there's no evidence that for the core symptoms of borderline personality disorder that medications work, that then it becomes a condition psychiatrists refuse to treat or won't treat. If you want to use medications and you're a psychiatrist, there's a ton of comorbidity that goes with borderline personality disorder, and you can use them. So, but medications aren't going to be the primary difference, although medications are going to be useful in situations when there is certain degrees of dysregulation, ADHD that are going to interfere with capacity, such as mentalizing, concurrent depression. So about 80% of cases, as I said, there is comorbidity. And that the person who has these awful behaviors is already stigmatized, and that once you make the diagnosis, you're further going to stigmatize the person who has it. So, again, it's interesting how cases get presented to our unit. So we've got this impulsive, self-mutilating, recurrently suicidal, drug-abusing patient with frequent mood swings and anger who's going to devalue your clinical skills. Yeah, no thank you. Next. Now, why is it left out? That, that truly, I mean, if someone were just that, well then, maybe I wouldn't either, but often what's left out is that there's tremendous compassion, there's often a lot of intelligence. Often people who've had to think about whether to live or to die are some of the most introspective, insightful patients that you can imagine. Because most of us live and we don't think about it. To think about death, to think about your life, means that you've done a lot of thinking. And now, thinking is not all it's cut out to be, because it gets you into a lot of trouble, but nevertheless, there can be a lot of introspection and self-reflection that actually makes them much more psychologically minded than other people. It's a sort of interesting group of patients to work with. And are the referrals balanced with the clinical strengths? Likability. It's just easier to work with a person that you like than ones you don't like. And those sorts of things. So I think that as, to sort of really take on a balanced perspective in terms of referring, in terms of talking about the behaviors that are getting people into trouble, but also the behaviors that are going to get them out of trouble. So if you're a clinician in the audience today, so just think about this. Do I routinely disclose the diagnosis of borderline personality disorder? So there you are, you see these behaviors in the back rooms and in rounds, you're saying borderline personality disorder. Do you make that disclosure to the patient as readily as you would any other diagnosis? I am treating you for bipolar. That's what I'm treating you for. I'm treating you for ADHD. I'm treating you for borderline personality disorder. And you say it with the same ease of manner and calm and confidence that you make all these other diagnoses. If I do, what are the risks and benefits? Now, to just say it, I mean, one of the ways to think about it, though, is to also say, are you using diagnostic tools and getting enough of a history to be confident about the diagnosis? You can't just say, after a 15-minute session, this looks like borderline personality disorder either. Okay, come on, hands up. Who's put deferred on access to when they knew? Yeah, there we go, the honest ones, and the rest of you. Yeah, well, I have too, so. Deferred on access to, or the insurance company calls and all of a sudden it disappears from the 5-axis diagnosis. Do I say, well, what is this stuff? What is borderline personality disorder? I question its validity. Again, the use it as a pejorative. Now, what about this magical age of 18? I've used this before, and it's really great because I hear other people now giving talks, and I hear them use the same example, so I love it because it's out there. But it's this idea that, you know, you're the therapist and you've been treating this person with bipolar disorder and on lithium, and, you know, they've got the acne and the kidneys aren't working all that well, but you know what, you have them on the lithium and everything, and they're 17 years, 364 days, and the next day they're 18, and you say, happy birthday, you're borderline. You no longer have to take the lithium. That's the good news. Now we can start treating you for BPD. It makes no sense, because a lot of people with borderline personality disorder, almost all of the people that I've met, there may be some out there who haven't, acknowledge that their difficulties started in adolescence. And for many of them, certainly after puberty, and there's different ideas about why that might be, but there you have that these difficulties started doing it, and to not begin to talk about the possibility misses an opportunity to discuss adequate treatments. So I was reading some books about this from very respected and senior clinicians in the field. And these were just these two excerpts. So one was, and again, famous people, data on the interplay of risk factors in the development of BPD do not exist at this point, primarily because BPD is not officially diagnosed until age 18. And what hurt me about that was, that's just not true. It can be diagnosed before 18. The DSM specifically allows it to be diagnosed before age 18. So for senior clinicians, respected in the field, to say that it is not diagnosed is just inaccurate. But I think that, you know, on the other hand, who are you going to listen to, right? Oh, well, you're the expert, and you're saying that. I was part of, with Perry and others, in speaking to Samsha, and they wrote in their paper, the DSM-4 advises extreme caution in diagnosing BPD before the age of 18. It doesn't advise extreme caution. The word extreme caution doesn't appear. So again, but here we have an official government body saying we're advising extreme caution. It's like the TSA, you know, don't step on this plane. Extreme caution. So there is no extreme caution. What I think that people are worried about is, you know, you don't want to just diagnose adolescents with a vengeance as borderline personality disorder. You know, like, okay, well, yeah, all my kids they're all borderline, because by that token, you know, what's the difference between that and adolescence? And I think that one of the things that I've talked about is that imagine identical twin children. Both are your kids, and they're doing exactly the same thing, and one has borderline personality disorder and the other one doesn't. How do you tell the difference? Because they're all having lots of sex, they've tried cutting, they've tried using drugs, and these sorts of things. And what the thoughtful clinician will look at is the function of what the behavior is, so that if one kid is having sex with a couple of people, but, you know, she's doing all right, and, you know, I thought, hey, sex is that sort of thing that adolescents do, and I'm trying, and it's okay, doesn't get them into too much trouble, that's just maybe normal adolescence. But if the other one is so desperate to feel connected that they will cross their values and do anything just to connect with somebody, that they do the same behavior, so manifestly the behavior looks the same, but the function of the behavior is different. Hey, you know what? Everybody's cutting in my school. I'm going to try cutting a couple times. Geez, that hurt. Okay, I'm not going to do it anymore. But, you know, for me, it helps me regulate my emotions. That's different. So let's look at the function, not just the extremity of the behaviors. But again, this extreme caution. It's not who's it helpful to. Well, you know what? I was going to diagnose it, but an official government body said I have to use extreme caution, so I'm not going to do that. Okay, what about the people diagnosed with borderline personality disorder? Do I share it with others? I mean, it's just a hard thing to do, you know, like, but I mean, most illness is a hard thing to share about. You're going on your first date, oh, and by the way, I have diabetes or I have asthma. And some things are just easier than others. I have borderline personality disorder because it's a very misunderstood condition. You know, people go online and the first thing comes up is like, you know, crazy people, stay away. So, you know, what are you going to say? Do other diagnoses seem more acceptable to me? Well, I suffer from major depression, NOS, or you know, I'm taking meds for these things. Do I feel blamed for my behavior so that when I do these things, I feel blamed? What about this idea is, I have asthma, I have diabetes, I have hypertension, I have cancer, I am borderline. You know, it's this idea of identifying, not separating. I have the condition of borderline personality disorder, I suffer from borderline personality disorder, I am borderline. Again, how are we using the language to make that separation between that which I struggle with and that who I am? Because if you are borderline, well then you're borderline. I mean, what are you going to do? What about the family members? You go through these interviews, and yes, but is there a medication that's going to be able to help my kid? Hoping for that magic bullet. Can you say, my child has borderline personality disorder in a loud, clear, confident way? Now everything that Alex said notwithstanding, because I think it's absolutely true, that once we make the diagnosis, we spend very little time on it. We're much more interested in function rather than fighting about this condition. But the problem is that accurate diagnosis is going to lead to more effective and accurate treatments. And when your child is diagnosed with this, the number of families who've said, oh, I just can't speak to my family members about this. Everything else, again, but this one I can't. So are you saying, grandma, grandpa, cousins, uncles, more psychoeducation? So, I mean, we used to non-disclose serious illness, the C word, or the, you know, and with HIV it was awful. They've got that thing. And now it's standard practice. Why? Because there is people, we treat people so fragilely. We don't want to tell them the truth because we think that they're going to fall apart. How the hell have they gotten to the point where they are today if they're that fragile? And the thing is that you yourself wouldn't want to be treated as fragile. But we imagine that we're going to treat other people as fragile as a compassionate point of view. And often the most compassionate thing is to empower someone to know about who they are, help them know about who they are, and to educate them. There's very little more empowering than that. So, when in doubt, again, the diagnosis of BPD can be difficult to make. The comorbidity of diagnosis can complicate accurate diagnosis of BPD. And I have to say that, I mean, there's some people who they say, well, does my kid have BPD or not? And after a month, I still don't know. Because there are features of it, but there's features of other things, and there's stuff that I don't even know what it is, and I say, these are just complicated kids. And you know, sometimes they're just multi-problem. You know, we're so caught up in categorizing, and I think it's important to categorize because it helps to orient ourselves and orient our colleagues about how we're thinking about things. But on the other hand, the brain, you know, is somewhat, you've got 10 to the power 15 neurons all speaking to each other, doing stuff that we don't have any idea about. To think that it categorizes nicely into 100 mental conditions is, you know, silly, really. And a lot of these conditions, I've found I've got this cohort of about now 20 patients who've got both Asperger's nonverbal learning difficulties and borderline personality disorder. And I could not imagine that these two conditions could co-occur. But they do. And it's very interesting how the black and white thinking works. Because black and white thinking of borderline personality disorder, all or nothing, is very familiar to many of us. But then it's compounded by the black and white thinking of Asperger's, and that is that it's certain rule bounds. Oh, well, I can't do that, because that's against the rules. And I have this, I was given this wonderful rock, actually, at the conference that we did in New York, and it's a Zen rock, and I just love this rock. It says, nothing is written in stone, and it's a rock. So my patients love it, but for the people who have BPD and Asperger's, say, well, that's wrong, because that is written in stone. And then you get into this huge fight. Geez, the hour's over, and we spend time deciding whether it was written in stone. Why wasn't it just the word nothing? Because then nothing would be written in stone. But then when they get emotionally dysregulated, right, then it's that all or nothing. Well, you've always hated me, you're just an awful person, you've always hated me, you never liked me in the first place, that kind of. So it switches back between these states and kind of being able to distinguish between them. And then, again, it's like, okay, you know what? I'm not going to make the diagnosis because I know that there's somebody brave down the road who will be able to send him to Dr. Miller over there and he'll make the diagnosis, but I'm not going to do it. So it can be accurately made, I'm not going to do it. So again, it's difficult to sometimes to make a distinction between, because a lot of the behaviors are very similar. Now, the other thing is somebody's calculated that you need 5 out of 9 of the DSM criteria. And if you play around with 5 of 9 DSM criteria, a minimum of 5 of 9, you get 256 different combinations. So you could have a room of 256 people with borderline personality disorder, and every one of them would have a different combination. So it kind of becomes complicated, like, if you were to say hypertension is anybody who's got a blood pressure over X, you say, well, these are the people who are hypertensive and these are the people who aren't. But with BPD, it can become confusing. There's internalizing behaviors and externalizing behaviors. Again, the comorbidity, so that you see some sorts of disruptions. And then the question is that disruption consistent with the borderline diagnosis or not? And sometimes where it becomes complicated is, for some people, the mood swings of borderline personality disorder are very classic, reactive, etc. But for other people who've also probably got some bipolar disorder and have some natural mood swings, being able to make the distinction between those two can be tricky. The other thing is, once you start seeing some of those behaviors, do you start to ask questions that might lead you to the diagnosis? And that's true. Anybody who's an expert in their field says, well, did you ask about sexual dysfunction? Or did you ask about dreams? Or did you ask about this? Is that, you're an expert in your field so that you know what to ask and you look for those things. So you have to be careful, because there's also the bias of the clinician who's going to be asking the kinds of questions that's going to make the diagnosis, and you have to be intellectually honest. And when somebody doesn't have the diagnosis, sometimes people will come to say, well, they're cutting themselves and they have borderline personality disorder, but what they have is a psychotic illness with voices telling them to cut, but because they want the treatment with us, they make that diagnosis, and we have to be honest about that. That if you can make the diagnosis, make the diagnosis. Ask the questions. Now, again, I used the word aggression earlier as an example of how we use language. As I said, I've never met Ephraim before, and I like him. There's something about his style that I like. If I had a kid who was struggling, I would like for him to treat, because I see a compassion, an irreverence, a thoughtfulness. So I have a reaction to this colleague who I'd never met before, and that's a reaction. We all have reactions towards each other. Now, if you want to label what happens very specifically in the therapeutic relationship, that specific reaction that people ordinarily have towards each other as transference and countertransference, then that's fine. And you could say that it's because of the special circumstances. But you're going to like some patients and not, and some patients are going to like you and others not. And whether those, we are here because of everything that's ever happened to us. And of course, past relationships are going to reflect in current relationships. So anyway, that's just a word about countertransference and countertransference. But often it's like, okay, that there's going to be these predictable reactions that are going to happen in the context of different things, and then I am going to end up hating this patient who is behaving in this way. So I'm not going to make the diagnosis because of these feelings that I have towards the person. So let's just go through these. So autonomy, it's a standard of care in medicine. Including the patient in decision is, I don't know what I meant by that, but it just that they're going to be able to educate themselves, maybe go online, maybe read more about it, be able to bring questions to their clinicians. It respects patient values, I think. Encourages self-determination. So here I am, I've come to you and I've got all these criteria, and what do I have? So, well, I'm not going to disclose that one. So what is the name of this thing for which I am being treated? Empowerment and mastery. Then the other thing is that as we've learned more about treatments, we're able to disseminate a lot more information and guide people to accurate treatments, and then treatments guide further research, and further research guides further treatment, etc. And again, we have a whole host of emerging studies on different treatments. For a lot of people, these treatments are long and complicated and arduous, and the theoretical underpinnings are somewhat tricky. And the majority of people who have borderline personality disorder, who are not so severe, requiring frequent inpatient hospitalizations, etc., there might be other ways. Maybe just psychoeducation as a model. And there are some ideas that psychoeducation and things like family connections can really help to lower a lot of the problems that people with BPD have. So clinician. So the other thing is now you begin to also have a shared understanding of what you're treating. So I don't think that I'm treating ADHD and that they think that you're treating BPD, etc. You have a shared understanding. Then there's also a realism about what's going to help and what isn't going to help. I mean, all the lithium and Depakote and Zyprexa in the world is not going to do much necessarily to treat. What are the goals? How can we set up goals, and how is our treatment going to help you meet those goals? And then we can make referrals specific to treatments specific for BPD. The other thing is that we used to get these calls that said, I have borderline personality disorder. I say, yeah. I said, why didn't you ever tell me? How'd you find out? I asked for my medical records. It's all over the place. You said depression and anxiety. Sorry. Yeah. I mean, people are going to find out, or they go online. I mean, the number of kids that come to our unit, significant number, have said, we were just looking for something, and there it was. That was a diagnosis that made sense to me. And then, Marshall Linehan discloses, or Brandon Marshall discloses, and they say, yeah, well, that's what it is. And they go to their clinician, hey, this is what I have. And then the other thing is to say, well, you've got a problem, but we're going to send you to my DBT colleague. He's really, really good. They say, what is DBT? Well, it's this treatment. And then they Google DBT and say that's borderline for borderline personality disorder. So they get referred and they find out in any case. So I just came up with this mnemonics. DBT Loves Mnemonics. It's mine. So, so reasons to diagnose BPD, so prove. So polypharmacy. Now, people come in on so many medications to our unit, and Mary Zanarini has shown that the health profile of 30-year-old woman with borderline personality disorder is that of 60-year-old woman. And a lot of it has to do with the medications that they're on. High blood pressure, obesity, metabolic syndrome, often a lot of smoking. So I mean, that's an awful thing to be burdened with. BPD, making the diagnosis, recognizes the complexity. Outcome, so characteristic course over time. Validation, I mean the number, I'm telling you, I'm so confident in making the diagnosis because the vast majority of people on having the diagnosis feel very validated and understood. The vast majority. And do try this at home or in your clinic. Try it once or twice. Hey, have you thought about this? And say, wow, this is so cool, thank you, you get it. You know, it makes sense. Okay, you know, one or two people might get angry. But the thing is, why ought they to be? Because this is a brand new concept to them. Here it is, okay? You know, say it like anything else, there it is. Oh yeah, that makes sense, that's what I have. Okay. So, and then effective therapy. Quickly, so what is not a solution? A lot of people have said, what about a different name? Now, I am absolutely for a different name, but you try to get, 10 experts in a room and try to come up with a different name, and, they all leave there, only 3 standing. Is that what happened with the crutch there? If I'm trying to come up with a name, there we go. So, because the thing is that, is it emotional dysregulation disorder? Is it interpersonal regulation disorder? Is it early attachment regulation problem disorder, whatever it is? And so, whatever we call it, people are still going to hate treating that thing that you call it. So, just simply changing the name. I do think, though, when we have a better neurobiological understanding, a lot of things are being now termed, reactive airway disease or whatever it is, some sort of thing that captures it, but just to change it for the sake of changing it. And it's so confusing that there was a massive fight in the DSM-5. People walked out. And it's the one thing that isn't going to change in the DSM-5. Everything else is changing, not borderline personality disorder, because people cannot come up with one standard way of sort of thinking about it, yet all of us clinicians feel that it's there. So anyway, we need to increase awareness. nea.bpd has done a wonderful job, and other groups as well. Tara and other groups have done a really wonderful job of trying to spread the word, increasing access to treatment. The other thing is that although there's some research on the impact of diagnosing, of disclosing the diagnosis in adults, we do have to do research on the impact of disclosing the diagnosis in adolescents. So with that, and so we have lots of time for questions. Thank you.